Hello. The topic of this video is high dose rate brachytherapy, HDR. This is quite different than the brachytherapy that we've been talking about up to this point. Although the same dose calculation protocols can be used, the applications are different. Because of the extremely high dose rate, you need shielded rooms and you need special equipment to introduce the source on a temporary basis into the patient. You can't have staff handling it, so it has to be sort of an automated remote control unit. So the technology is quite different and the applications are quite different, but in a way it's quite a simple radiotherapy, and it's used for like a number of disease applications that we'll go over in this video. All right, here we go. So first of all, you may want to go back and review some of the concepts in brachytherapy. These were in video 4.1, where we talked about LDR, less than 2 gray per hour, which uses isotopes of short half-life, low energy, and those are typically permanent implants, versus HDR, which is greater than 12 gray per hour, long half-life isotopes, high energy, and these are temporary implants. A very important isotope is uranium-192, and what I'm going to be talking about in this video, everything uses that. It emits high energy photons, average energy of 380 keV, and it has a 73.8 day half-life. So how is this used clinically? For early stage cervical cancer, often brachytherapy is used alone. In later stage cancers, it can be used in combination with external beam, sometimes with chemo, or concurrent chemo-RT and then brachytherapy. This is in areas where these resources are all available. Then in the latest stage disease, it would be brachytherapy, sometimes with external beam, and thus with a palliative goal, try to stop hemorrhaging and provide support for the patient. Here is an example of how this is used. This is a vaginal cylinder used to treat superficial vaginal cancer, early stage endometrial cancer, stage 1 with some risk of recurrence. The cylinder goes into the vaginal canal, has a diameter ranging from 20 millimeters up to about 40 millimeters, can be selected, and then the source goes up through the middle and gives you a dose around the wall. So you would prescribe either to the surface of the applicator or to a 5 millimeter depth beyond it. Now, there are other kinds of applicators that can be used for other purposes, and we'll get to those in a minute. But first, let me show you how the device works in general. So here's a picture of the vaginal cylinder, and you can see it has a tube going through the middle, and that will plug into a device which we call the remote afterloader. This is the device that houses the uranium-192 source, which has a high activity. When it's installed, it can have an activity of 10 curies or 11 curies, depending on the unit that you're working with. So very high activity. So we're hooking this tube up here, and then the source is going to go through that tube and into the applicator when you're ready. But otherwise, it's stored in the safe in the unit. So here, plugging in the transfer tube. This will go into the channel 1. You can see in this unit actually has 20 channels, but here we only need one of them for this vaginal cylinder. We'll see other cases in a few minutes. And then when we're ready, we leave the room and the treatment starts. So the treatment is determined by these dwell positions, the red points shown here. The source is going to go in, stop at each of these points for a specified amount of time, and then it will retract and be done. So actually, before the active source goes out, what happens in these units is a dummy source goes out. A fake source with no activity in it goes all the way out to the end of the applicator and then comes all the way back. That's to make sure that the channel is clear and the lengths are right. And then after the dummy source is back, then the live source goes out and you treat. The dosimetry of these treatments is calculated and determined according to the TG43 protocol. It's exactly like what we talked about in the previous video, so you can go back and review that if you need to. So now I'm going to talk a little bit more about different applicators for gynecological cancers. Applicator is just the hardware device that you use to get the source into the position you want. I'm going to talk about the tandem and ring applicators and the tandem and ovoid applicators. Let's look at the geometry of this and the anatomy and talk about the clinical goals. So here I'm showing the geometry from two different views, laterally and anteriorly. So if you look laterally, the applicator here goes into the vaginal canal. This circle here is the ovoid in this case, and it sits at the entrance to the uterus, the cervix right there. You can see where the bladder is, the rectum. And then inside intrauterine is the tandem. That's this line, the rod that goes in this way. And then there's an angle. If you look at it from the front, here's what it looks like. And you've got the two ovoids sitting here at where the cervix, the cervical os, that's the opening of the cervix. So let me show you a little bit about applicators. There's a lot of equipment here. I'll show you how this goes together. So first of all, you pick out the tandem that you want, and you would set this vaginal cuff. That's the white ring. It's going to determine how far it goes in how far the tandem goes in to the uterus, where it sits. All right, so then you're going to assemble the two. These are the two channels that will hold the ovoids. Typically, you do these one by one, but here we're just for demonstration to do it together. And then you pick out the ovoid, and you put that on. So typically, you're using the largest ovoid possible, the largest one that will fit, in order to reduce the mucosal dose. So there's one on each side, and those go in on each side. So then what you see here is there's quite a bit of freedom in the applicator in terms of how you adjust this. You can move it side to side. You can push it in and out. You can put it up and down. And you can also squeeze the two ovoids together or push them apart. So it allows a lot of adjustments that are possible to get the right dose distribution. Okay, and then you'll see you want here the tandem to basically be perpendicular to the axis of the colpostats here, or the ovoids. All right, so at this point, the applicator would be inside the patient. Here, you'll see the three channels. This is where the HDR source goes. So to go into the tandem and into the two ovoid channels, and each of these are labeled so that there's no confusion about where they're being connected. And they connect to a transfer tube that then goes into the afterloader, as you saw before. Here I'm showing the different tandems. You can see different angles are available to select to match the patient anatomy. Also, these ovoids or colpostats have option where you can have shielding built into them. You can see that, and that's basically to shield anteriorly and posteriorly, shield the bladder and the rectum if needed. So the other main applicator option we have is shown here. This is the ring. So we would have a tandem and ring assembly. Here's the ring, and to assemble this, you just simply put the cap on. That's just to hold it away from the tissue a bit. And then so you have a ring, and the source will go around in that ring in a circle. And then the tandem goes through the middle of that. So you pick the tandem with the angle that you need, and you insert that there. It clips in, and there's screw it down, and you're done. So it's a little bit simpler than the ovoid system. So now let me talk a little bit about how doses are specified and reported. This is the Manchester system, which is a historical way of doing this. And here are some references for this. ICRU report number 38, and then more recently ICRU report 89, which is an update, and also gets into volumetric imaging using CT or MRI, which is the more emerging modern way to do this. So here are how these points are defined. So first of all, point A is 2 centimeters up from the top of the ovoid and cervical os, and 2 centimeters over from the tandem. That's a prescription point. And then you also have point B, which is 3 centimeters lateral to that, for the pelvic sidewall. Now, traditionally, you would take radiographs of the implant in the AP and the lateral, and that would allow you to define these points. Also, you have a bladder point. To define that, you put a Foley in, fill it with 7 cc's of contrast, and the bladder point is then on the posterior aspect of this Foley balloon. The rectal point, that's half a centimeter below the vaginal wall. You typically put a gauze in, a radiopaque gauze, and that shows the posterior surface of the vagina. So here's a typical isodose distribution. You can see this kind of a pear shape from the tandem and ovoid, and you can control the shape of this by how much dwell time is placed in the ovoids versus the tandem. Here's a typical prescriptions. They go anywhere from 5.5 gray times 5 to 7 gray times 4. And then there are some limits that you should respect in the various normal tissues. So point B, typically 30 to 40% of the point A dose, limits on the rectum, limits on the bladder, and then limits on the mucosal doses. Again, these are all point doses as defined on radiographs. I'd like to spend a couple minutes talking about applications for HDR beyond gynecological cancers. Here's one. This is for breast treatment. So there's several applicators available. Here I'm going to focus on the Savvy applicator, which is a multi-channel applicator. A dummy is put in at the time of surgery into the lumpectomy cavity, and then post-surgery, patient comes back, and the applicator is inserted. This is a 6-channel applicator, and it's expanded, and then it can treat the walls of the lumpectomy cavity. And you have quite a bit of control over the dose distribution because you can control the dwell times in these 6 different channels. There are different ways to do this. Now, other kinds of HDR applications include prostate brachytherapy with HDR, intraoperative radiation therapy with a flap, and other sites as well. All right, so there you go. HDR brachytherapy in a nutshell. I hope this is interesting. A lot of times if you don't work with this every day, you don't get to see all the equipment and everything. So this gives you a little bit of a window into this. I wasn't able to talk about everything, as you can imagine. So here's a reading list for you to dig into further into this topic that's actually pretty vast. All right, so that is it for brachytherapy, and I hope I've talked about the basics of all you need to know, because there is more. But anyway, there it is. We'll see you in the next video.